Dr. Kernberg, for your kind introduction. We have about an hour, right? I should talk about 45 minutes, so to leave time for discussion, 15 minutes. Okay. I'll try to give you an overview of our of the psychotherapy, psychodynamic psychotherapy we have developed for patients with severe personality disorders, for borderline personality disorders, but really for all patients with different personality disorders of a severe kind, what we call borderline personality organization in the broad sense. But it seemed to me that to give you an overview that would make sense to you, I should do a briefly review of the field in total. So as I don't know where you are and what you have been involved in and studied, forgive me if some of the things I'm going to say are well known to you. I trust the others are new developments that come particularly from the research efforts at our institute, in which I think we have had exciting developments in recent years. These are the members of our institute. John Clarkin is co-director, and by the way, he's the main author of the manual of our treatment that I warmly recommend to you. It's by John Clarkin, Frank Yeomans, and Otto Kernberg, and it's called Psychotherapy with Borderline Patients, published by Basic Books, 1998. And it's not written in a manual form, but it's actually the manual that we have applied and taught and empirically researched. And I believe it's fair to say that it is the only manualized long-term psychodynamic psychotherapy, hopefully clear enough that it should be understood by people who have not had psychoanalytic training, and sufficiently in depth not to suffer from the kind of superficiality that unfortunately sometimes these psychotherapy manuals have. You know, this is your couch and this is your napkin. Let me remind you that personality is an umbrella concept that includes the following main components. Temperament, which is the genetically determined, constitutionally given reactivity of the organism, particularly affective reactivity, but also cognitive and perceptive reactivity. The importance is that as we are discovering genetic dispositions to many psychiatric disorders, the fact that genetic disposition translated into certain central nervous system structures and neurotransmitters eventually shows as temperament, which indicate the basis on which then environmental trauma and experiences develop into a particular form of psychopathology. So temperament is the inborn reactivity that you have from babyhood on, and that determines affect activation, the intensity, rhythm, thresholds of affect activation, particularly in relationship with significant others. And that affect activation in relation with others, particularly mother, from the beginning of life on, creates interactions that then are internalized as affective memory. And affective memory that then determines patterns of behavior as it is gradually learned how you interact with others. And those habitual patterns of behavior we call character. So that character is the result of interaction between temperament and environmental relations under affect-driven relationships. And character is reflected subjectively in what we call identity. What is identity? Identity is the integration of the concept of self and the concept of significant others. In other words, an integrated view of ourselves longitudinally throughout time, cross-sectionally through different experiences that orients our relation to others, while at the same time our understanding in depth of other person complements it in that we relate to others not only in terms of their immediate behavior, but what we know about their permanent relationship. With a normal identity, you have a sense of internal continuity, a sense of continuity and predictability of what you're going to do. And with a normal identity, you come home, you open the door, your wife smiles, you think she loves me, You open the door, your wife is serious, you don't think she doesn't love me, but something is worrying her, right? I mean, you're secure of her love regardless of her immediate gesture with a normal identity, and you say, what's going on? If you have an identity, what we call identity diffusion, there's a sense of this internal discontinuity. You don't know how to predict your behavior. It's as if you were different people under different circumstances. You can't predict it. You're at the mercy of states of mind that you can't well put together. And you're at the mercy of the immediate behavior of the other person. Open the door, your wife is serious, she doesn't love me. So your borderline patients, anytime you are tired, will immediately think you want to throw them out or whatever. So identity is the subjective reflection of character. Character is the behavioral manifestation of identity. These are mutual complementary and extremely important aspects of the personality. By analyzing character patterns, you diagnose them what kind of personality disorder they have. By analyzing identity, you can decide immediately whether it's a moderate or mild personality disorder or a severe one in the mental status examination. I'll say immediately how you do that. What we do with our mental status examination with personality disorder, we start out asking them for all their symptoms. Complete symptomatic lists and awareness is essential. Then we go on to ask them about how they function in their present life. We want to know everything: work, home, family, studies, sexual relations, sports, leisure time, hobbies, everything that we may get to get the feeling for how the person is functioning right now, which gives us a sense of their behavior patterns and gives us immediately the main abnormal behavior pattern, which will indicate what kind of personality disorder they have. And then we ask them, now I'd like you to describe to me the most important persons in your present life. We know them already because we have asked them about their life situation. Can you describe your husband to me? Can you describe your friend? Can you describe your boss? And if a person is able in a few minutes to give an integrated description of a significant other person, that speaks for good identity. If it becomes totally chaotic or cliché, it's one indication of identity diffusion. That requires some practice. What we teach our residents how to acquire this is ask these things to the severe personality disorder that you see in the hospital, and then ask your friends, because among your friends probably a majority don't have a severe personality disorder. At least it's probable. And so after asking them the most important persons in their life, then we ask them, now can you describe yourself to me so I get a live picture of you? And same thing, if the person in a few minutes is able to describe essential aspects of oneself, good identity. If it becomes chaotic or cliché or in total discrepancy to what you have learned about the person because you just asked them about their present life and you've been interacting with them, it indicates identity diffusion. So the combination of the analysis of description of significant others and description of self gives you that answer. It requires practice, but it can be learned, and it's extremely helpful for general orientation. I repeat: symptoms, present personality, identity, and then we, in the cases that seem most severe, we ask for reality testing. That's easy, elegant, but essential only in the cases that look very flaky, kind of spooky, strange, space cadets, either because of their behavior or their affect or their thought content or the formal organization of their thought process. Something is wrong there. And after we have asked the other things that I told you, if the patient shows that, we ask him, I have noticed in our interaction something that seemed strange to me in your either affect or thought or behavior. You describe it in a tactful way, non-critical. And you ask the patient, can you see what seems strange to me? If the patient can see that and says, oh yes, and gives you an explanation that makes it less strange, reality testing is maintained. A patient is very suspicious, and you tell him, look, you look as somebody who has been dropped behind enemy lines. Can you see that? And the patient says, well, I'm cautious. Yes, you're right. I've had bad experiences with doctors. Now, that's more reasonable. If the patient, when you ask him that, reacts saying, what do you mean, doctor? Are you accusing me of anything? Then reality testing is presumably lost. This is an easy way to differentiate between personality disorders and psychosis. Very helpful. And of course, if the patient is psychotic, you do the usual mental status examination for psychosis. If the patient is definitely non-psychotic, you know you are at the area of personality disorders, and then you can go into the past history and everything else. You notice we start out with present illness and only go into past history after we have clarified all the other things. So this is the important of temperament, character, and identity. Then what is important, then another factor of the personality's intelligence, that's pretty obvious. We sometimes forget it in the sense that you need to have a normal IQ for the kind of psychotherapy I'm going to describe, which is very abstract communication. And finally, the ethical value systems, the superego in psychoanalytic terminology. Why is that important? Because it is the most important prognostic indicator for all kinds of psychotherapeutic treatments. Cognitive, behavioral, psychoanalytic, gestalt, whatever you want to. How do you evaluate that? You evaluate it by any antisocial behavior present, from being dishonest with you, deceptive, to lying, stealing, irresponsible with money, etc. Psychiatrists are often reluctant to ask patients about this. You have to do it carefully. Have you been ever tempted to do things that might get you into trouble with the law? Or if the patient doesn't seem to be honest with you, I have a sense that you're not telling me everything. Am I wrong? A patient who is very honest gets upset if you imply that the patient is not being honest with you. Somebody who is dishonest may give an explanation calmly to get you off his back. So it's an important aspect of the mental status examination. These are the main components of the personality. And what is a personality disorder? A personality disorder is a significant alteration or reduction in the capacity to relationships to the psychosocial environment as well as to one's own needs. It is characterized by either inhibition of certain character features, or by exaggerated development of others, or by contradictory alterations between excessive behaviors in some areas and then inhibition in the same areas at other points. Just a brief word about classification of personality disorders. In the DSM that you have, they are categorical. Each personality disorder is a separate category. We question that nowadays because there are internal relationships that make it better to think of them as continuous. And the DSM-4, the ICD-10 are typically categorialists, while the researchers have found continuities, particularly in terms of these dimensions. I don't have time to go into a critique of that. I just would like to say that particularly the dimension of extraversion, introversion is a temperamental one, whether you are extroverted or introverted, and indeed very important in the classification of personality disorders, and that this dimension indicates the ethical value systems that I mentioned before, same as this one. So there are problems about this as well as of this, and ideally they should be integrated. Clinically, these are very helpful, except that they miss in the continuity. I'll show that to you immediately. These are excellent research instruments, but they are useless in the clinical definition of patients. That's the paradox, and we have the official literature has not yet resolved it. In addition, we have a problem in that the theoreticians in the field are divided between the pure biologists who see everything coming from genetics and temperament, and the psychoanalysts who see everything coming from the environment, and we have evidence that the two are important, and the real issue is how to integrate them. I'm sure I'm not saying anything new to you. This is the definition of the borderline patient according to DSM-4. I think you are familiar with it. It's a list, and all in all it's fine. It defines one constellation of severe personality disorders, and here is the concept that I mentioned to you earlier of borderline personality organization, meaning the entire group of severe personality disorders characterized by identity diffusion, which you already understand, by primitive defenses. And let me just say that primitive defenses are defensive operations centering around primitive dissociation of psychic experience or splitting, when they include splitting, projective identification, denial, the primitive idealization, devaluation, and they are all characterized for having behavioral aspects. They show in the interaction with the patient. They distort the interaction from moment one, in contrast to the classical defense mechanisms described by Anna Freud, your beloved friend and teacher, who are those characteristics of the milder personality disorders, and are the ones originally also mentioned in part at least by Freud, center around repression and negation and reaction formation, intellectualization, rationalization, and they don't show up in the initial interviews. They show up during long-term psychotherapeutic and psychoanalytic treatment. So when you see severe distortions in the interaction, you probably have a patient with a severe personality disorder. But the most important and elegant issue is identity diffusion. And here it says the patients have decreased reality testing. I told you that they have maintained reality testing. I'm going to modify that now, saying that although reality testing is maintained, they have a decrease in their capacity for tactful interaction. They are tactless. They don't get the subtlety because they can't evaluate other people in depth. And of course they get into trouble all the time because of the lack of capacity to evaluate themselves and others in depth. Let me briefly go through what we know about the etiology of the severe personality disorders, and I'm using the borderline personality disorder really as a kind of a prototype. The most important thing is that all these patients have an abnormal affectivity and excess of what is called negative affect or aggression, really, in the literature. Negative rage, anger, anxiety, contempt, irritability. So a predominance of negative affect and of impulsivity, lack of affect control. It used to be thought that that was one thing. When there's excessive negative affect, you just fly off the handle. Now careful research has shown that there are really two aspects here: excessive negative affect and lack of cognitive framing of affect. And there are different. We have in the research with our borderline patients using imaging techniques. This has been done by Silverzweig with the help of Posner, top expert in studying what is called effortful control, cognitive control from childhood on. We have found, and other researchers found, that borderline patients have an excessive activation of the amygdala, center linked to activation of negative affect, and a defective activation of the prefrontal cortex and the anterior part of the cingulum, which are involved with cognitive control. I'm oversimplifying the field, but for this purpose, the combination of the two makes for explosive affect, excessive affective activation. That is at least in part called by genetic disposition. And you know, there's research on various transmitter systems, particularly predominant in this serotonergic system, but also the dopaminergic, the noradrenergic system. And the truth is we only know about 6, and probably there are 12 or more involved, so our knowledge is not as definite as we believe. A pathology of transmitter system and of central nervous system structures combine then in the expression of genetic disposition into temperament, as I mentioned, and temperament gets involved into object relations, which is the technical name for affectively involved significant relations with others. And we know now there are 3 types of major causes of pathology in the relation with others. Environmental factors that increase aggression, which is pathological attachment, and there is very important research going on regarding the difference between normal and pathological attachment. Trauma, by which is meant severe chronic physical abuse, sexual abuse, or chronic witnessing of physical sexual abuse, and family pathology, particularly chronic chaos in the family, blurring of ordinary lines, boundaries between generations, chronic unpredictability. Doesn't matter if parents are bitches and SOBs, as long as they are predictable. When they are unpredictable, everything is much worse. Here, the general theory that we have evolved is that excessive disposition to negative affect plus impulsivity, lack of cognitive control, are predisposing factors that then lead to identity diffusion if they are reinforced by severe physical pain in the first years of life. By the way, severe chronic physical pain in the first year of life increases negative affective reaction, psychic trauma, abnormal attachment, family care, and even cognitive deficit may contribute to lack of clarification of interpersonal relations, leading to borderline personality organization that then, if it is extroverted, goes into the borderline personality disorder, and the milder histrionic, narcissistic, antisocial, if it's introverted, into the schizoid, paranoid, and schizotypal. And on this basis, we have proposed, let me say that as a consequence of borderline personality organization, these patients develop lack of anxiety tolerance and time perspective, disturbed object relations, serious difficulty in work and love, breakdown in work, breakdown in love relations, and sexual pathology. And we have found 2 levels of sexual pathology. The most severe borderline patients, I'm using now borderline in the broadest sense of borderline personality organization, the most severe ones with a severe general inhibition of sexuality because the negative affect, the aggression drowns it. So they don't have any capacity for sensual activation, no sex, no masturbation, no nothing. And the milder level in which you have chaotic sexual behavior with persistence of what is called polymorphous perverse infantile sexuality, combination of homosexual, heterosexual, masochistic, fetishistic, sadistic, exhibitionistic, voyeuristic trends. So there is chaos in object relations in their sexual life, which looks much worse at the beginning but has good prognosis, because if these patients improve, that can be channeled in love relation. While those who have the severe inhibition, they are the greatest problem. And for those patients, what we do is in the advanced stages of our psychotherapy, we may combine it with sex therapy that then reinforces mutually those approaches. But these are really very difficult cases. And superego pathology, in the sense that severe identity diffusion also predisposes some patients, not all, to the kind of deterioration of internalized value systems that I referred to before. I have not given you a general classification of personality disorders, but I've indicated to you that therefore you can classify them according to whether they are milder or more severe, and of an introverted and extroverted type. They have different clinical presentations, but the treatment actually is the same. This is an overall classification of personality disorder. Don't get frightened by, don't copy it. I'm just saying that with these criteria, you can relate all of them. The only thing I want to point out to is that you see there are personality disorders that are not on the DSM classification system, which is, and they are all from the DSM system are there except the avoidant personality. We are arguing whether it exists or not. We are hotly divided in our institute. But the important thing is here, these are the neurotic ones, the higher levels, what we call neurotic personality organization, the obsessive compulsive, the depressive masochistic that you find in the appendix of the DSM, and the hysterical, which was missed simply. And here are the borderline personality organization, the milder ones and the more severe ones. The central one is the schizoid on the introverted type, and the schizotypal, which is the most severe part of it, and it's linked to the paranoid personality, and the hypochondriacal, which has been missed in the DSM classification. On the extroverted side, the borderline, and those with a strong predisposition to affective disorders, the rare hypomanic missed in the DSM, the cyclothymic, and the depressive masochistic. And then the narcissistic as an important secondary elaboration of the borderline, the histrionic, a milder form of the borderline, intermediate between borderline and hysterical. And for the narcissistic, what is very clear, and the DSM misses that completely, is that the more severe form of those are precisely what culminates in the antisocial personality proper, the antisocial personality proper that has prognosis 0 for all psychotherapeutic treatments. So you have to make this diagnosis in order to save time, money, and know that your task with such patients is to help the families before the patients. The syndrome of malignant narcissism is intermediate. We have described that, and it's a severe narcissistic personality with antisocial features, paranoid features, severe aggression, but not an antisocial personality proper. So you see here, this is mild severity, extreme severity on the vertical, introverted, extroverted, introverted on the horizontal. And this classification we have been able to empirically demonstrate by the study of factor analysis of our patients, but I won't go into this now. Here we come to the basic theory of that explains the syndrome of identity diffusion, and I'll put it in the simplest way. It is called psychoanalytic object relations theory. And let me tell you that contemporary psychoanalysis, this is a centerpiece of contemporary psychoanalytic thinking. And the theory starts from the basis that in all intense affective interactions, there is a mental representation of this interaction built up, and that mental representation contains a representation of self interacting with other under the dominance of a certain affect. It's a dyadic relation that is internalized, and at the beginning there is a complete separation between those under the effect of positive affects and those under the effects of negative affects. So there is a split organization of affective experience. It is as if the child, when it's happy with mother, builds up an ideal image of the world, and when a child is unhappy, builds up a sense of terror and horror, and through projection, the image of a bad mother. Under normal circumstances, this is a transitional development in the, and it's argued whether it only takes the first 6 months of life or the first 3 years of life. And then it leads into a normal organization by which the concept of self is integrated and the concept of significant others is integrated, and they are differentiated in terms of their their gender. This represents normal identity. And when this is not, why is it not achieved in many cases? Because there's such an intense aggression that the integration would drown the positive, be very destructive. So to protect the positive, this is maintained. And this is precisely the organization that patients have with borderline personality organization. And what we try to do in the treatment that we've developed is transform this into this. So this is an explanation of what I just told you. Needs, well, you're able to read it. Yes, I move on. Here we go into the neurophysiology of self, and I'm going to announce that. Now, regarding treatment of patients, there are 3 types of psychotherapy that are used. First, supportive psychotherapy based on psychodynamic models, identification with the therapist through cognitive support, affective support, environmental intervention, and clarification and tactful confrontation of disruptive experiences and behavior. It is a treatment that tries to provide it's common sense treatment that should permit the patient to identify with the therapist and deal better with his life situation, using identificatory models, being attentive to transference developments, not to interpret them, but to use them for re-educative means, and trying to help the patient deal with this defensive operation. If the patient all the time is suspicious of women by projecting his own rage with women, we point out to him that he treats all the women as if they were terrible. It may be that he's wrong because he tends to be so suspicious, so he should give himself a chance to see whether there are differences. So we deal rationally on a conscious basis with this defensive operation, re-educatively with transference, and provide him with better adaptation between his instinctual excessive aggressive tendencies and the need to adapt. Dialectic behavior therapy is a cognitive behavior therapy developed by Marshall Linehan, which has been used effectively, particularly with parasuicidal and suicidal borderline patients. It is a clearly focused and manualized treatment that is spelled out in a, by the way, supportive psychotherapy, it's the most prevalent psychotherapy, and I warmly recommend to you the book by Lawrence Rockland, Supportive Psychotherapy with Borderline Patients, who was our expert in our institute and wrote that book, and I believe I'm not biased in saying it's the best book on supportive psychotherapy in the literature. So I warmly recommend it to you, basic books. I don't remember the year it was published. Marshall Linehan her manual is published, and I warmly recommend it. It's very clear, very comprehensive. Dialectic behavior therapy can be learned easily. There are courses on that. Takes five days. That's all you need. And then you have to get supervision throughout the year. And then a year later, you get a 5 days booster of it. And it's so that it's easily to be acquired. And supportive psychotherapy, if you have a general background in psychodynamic psychotherapy, as you get in a residency and study carefully the book by Larry Rockland, and of course with supervision, you can acquire it. In dialectic behavior therapy, there are 2 major techniques: validation of the experience and self of the patient, what we might call a strong strengthening of self-respect and self-regard, self-worth on the patient. Behavior therapists don't use that language and talk about validation, but essentially that's one aspect, to tell the patient under those circumstances you were absolutely right in feeling the way you are feeling. And at the same time, skill training, saying, look, the way you're dealing with this situation is problematic. Let's see if you can learn ways to deal with it which is more effective. So the patient is found right or in what he feels, but wrong in the way he reacts, which is not a critique of him, just of his method of using his feelings. So there is the combination of validation and skill training applies first to self-destructive behavior, starting out with therapy-interfering behavior, starting with self-destructive behavior therapy, and then life-interfering behavior, and then increasing general behavioral skills, mindfulness, interpersonal skills. And then in a so-called stage 2, which has been much less developed and in all fairness is yet a kind of an open area for this therapy, processing of the past, and finally increased synthetic self-function, which is really hasn't been developed. This is what has been applied in the treatment of borderline patients. And our treatment, which is transference-focused psychotherapy. Now, what we have done is to develop this over a period of 25 years. And first, we manualized it. We treated patients informally. Then, with the manual, we did a first project with 17 patients, comparing them with treatment as usual, and found that it was an effective treatment. In fact, it's as effective as supportive psychotherapy, at least, and cognitive behavior therapy. And then we did the present research just completed, in which we treated 90 patients, 30 with DBT by DBT therapists under the leadership of DBT therapists, 30 with TFP, transference-focused psychotherapy, and 30 with supportive psychotherapy under the leadership of people who are convinced, each of them with therapists who think their therapy is the best, and applying to all of them a target-oriented psychopharmacological treatment based upon Solow's algorithm, Paul Solow's algorithm of what kind of medication you use for borderline patients. And let me say in this regard that in addition to these three psychotherapies, psychopharmacological treatment is helpful, helps about 30% of patients, centers around the use of low dose of typical neuroleptics, antidepressant medication, mostly SSRI, and under special circumstances MAO inhibitors, and mood stabilizers, also much more questionable. I don't have time to go into this right now, but in general there's an agreement of all the researchers that psychopharmacological treatment alone doesn't do the job. On the contrary, its effects wears off. Patients end up chronically after having had 10 types of medication and just where they started out with. So you should always combine it with a psychotherapeutic approach. Any of the three. There is no, our study is the first comparative study of those three approaches. We have only preliminary results, but I can tell you that clinically, most probably, all three work, but they probably work by different mechanisms, helping different kind of patients. The advantage of cognitive behavior therapy, that it's a relatively non-expensive treatment that can be carried out by relatively non-highly specialist therapists. It takes one group session a week, one individual session a week. The advantage of supportive psychotherapy is that it can be done very flexibly, once a week, every other week, twice or three times, whatever, and a general, well dynamically trained psychiatrist can do that. The advantage of our TFP is that it attempts to change the personality radically, but that means that it makes much more requirements for the training of therapists. It's expensive in training of therapists. It requires 2 sessions a week. It doesn't work with less than that because you don't have the intensity of treatment that permits you to do what I'm going to summarize, and help some patients and not others. And I'll at the end just give you a list of prognostic features. Our treatment can be described with strategy, tactics, and techniques. The strategy is first, in the treatment sessions, to clarify the activation of what we call primitive object, the self and object representation in the primitive object relations that were traumatic and have been dissociated mutually, and that show up as kind of inappropriate, quote, crazy behaviors of these patients that we translate metaphorically in a specific interaction. And the metaphor may be any metaphor. Patient behaves like a frightened prisoner who treats the therapist as if he were a prison guard, or like a hungry baby who treats the therapist as if she were an indifferent mother. These are metaphors. And this distortion of the objective relationship is verbalized by the therapist. And at the same time, the rapid alternation between that interaction and its opposite, where the patient starts behaving like a sadistic prison guard and puts the therapist in a position of his victim, or the patient acts like a different mother, and the therapist is in the role of a demanding baby. In other words, the rapid alternation of roles of these primitive object relations are activated by these patients in the transference from session 1 and are systematically and repeatedly clarified with their role reversal, both in the segment of positive and negative interactions. In other words, of ideal relations that pop up at times in the session, and the horrible persecutory ones. So separately we analyze those, and finally we integrate them, pointing out to the patient how these opposite idealized and persecutory relations are really split off aspects of ambivalent relation toward an important object that is experienced ambivalently. That is done throughout many months, gradually, and years of treatment. That's the overall strategy. This is expressed in each session by certain tactics, which means first setting up controls and protecting the treatment against severe acting out, focusing on what are the dominant affective and transference themes in that sessions, having techniques for containing affect storms, and translating acting out and somatization into the object relations that somatization and acting out are defending against, and deciding in each session by the priority of interventions by urgency, such as intervention to protect the patient, to protect the treatment, to assure honesty of communication, to protect the safety of the therapist. So we have priorities of subject that have been to be taken up within the overall effort to analyze these split off primitive transferences gradually. The techniques are interpretation of these relationships, and by interpretation we mean first clarification of what the patient thinks and experiences, then careful confrontation of what we observed in the behavior, using our countertransference to clarify it further, and on the basis of all that then to be able to analyze the transference. We maintain a position of technical neutrality, which doesn't mean disgruntled indifference, but trying to not be seduced into taking a stance in the issues in which the patient is conflictual. So we don't take the side of one or the other of the patient or the people with whom he has conflicts, or if he attacks us, we don't counterattack, but try to analyze what is going on, what kind of perception of us determines his behavior, so that countertransference utilization is a very important aspect of the technique. I have already mentioned about pharmacology, the three types, and I have really not talked about indications in the sense that severe panicky anxiety is treated first with antidepressants and under certain conditions with low-dose neuroleptics, disorganized thinking, overvalued ideas, paranoid orientation, dissociative episode with low-dose neuroleptics, and mood stabilizers are really typically only indicated if and when there is an honest-to-God bipolar illness, and you know that how this diagnosis is exaggerated and done poorly everywhere, or if there is an extreme aggressive behavior for which the mood stabilizers are helpful. They are not helpful to normalize affective lability of borderline patients who do not suffer from a major affective illness. Therefore, the differential diagnosis between major affective illness and personality disorder is crucial. The treatments that the three treatments act, you remember, that the main etiological factor are negative affect, impulsivity, and identity diffusion. And the psychopharmacology and DBT and supportive act on negative affect and on impulsivity. And DBT and supportive provide increased self-esteem and identification. TFP really focuses on the resolution of the identity and therefore on the basic feature that's going to normalize the personality structure in total. I don't have time to go to the findings all in all. Let me, oops, there's something missing here. Well, I'll just tell you, let's just keep that there. Prognosis. We have the, what I'm telling you are tentative conclusions, and some of them may be proven wrong, but this is our best judgment on the basis of clinical experience as well as our own research experience and review of the field. Prognostically, for the psychotherapy of all severe personality disorders, most important prognostic feature, antisocial behavior. If that's absent, that's already good. Second, the maintenance of object relation. The patient may be behaving crazily, but is able to hang in there with significant relationships that are not exploitive. Of course, if they're only exploitive and parasitic, that doesn't count. Third, secondary gain. That's a plague. Patients in the state of New York get SSI, social support, protected housing, and they live gloriously at the cost of the state. I wouldn't say, maybe I sound to you cynical or I'm saying politically incorrect things, but it's a fact that then the treatment, they have learned to live a parasitic existence. They are happy to get treatment as long as they don't have to improve because they might lose the social support. Michael Stone, has developed the Michael Stone 1.5 formula. The 1.5 formula says if the patient has a chance by his education, background, intelligence, knowledge to earn 1.5 times what he gets in social support system or more, there's a chance for improvement. If not, the prognosis is very bad. Unfortunately, it's true. Other negative therapeutic factors are the development of severe negative reactions, patients getting worse when they feel helped. There are several types of those. The mildest one, out of unconscious guilt, that has been described in the psychoanalytic literature, that has very good prognosis, no problem. Then the unconscious envy of the therapist who is helping them, very prevalent with narcissistic personalities, but that can be treated, interpreted and resolved. And then finally patients who have severely brutalized, battered, and who develop a deep fantasy that only somebody who kills them loves them and provoke every therapist to become their enemy. Those may have bad prognosis with whatever is done. That's overall prognosis. How to indicate differentially the three treatments that I mentioned, that is still an open question. And I don't have anything definite to say, and therefore I'm leaving it open, except that you have these three alternatives and already you know some of the advantages or disadvantages of those treatments. Okay, that's it. Thank you. I'm sorry it took 10 minutes.